Good afternoon. First of all, I want to thank the organizing committee for accepting my case. Actually, my case is simple, but resulted in complication for the patient. So the title, what to do when you have ectasia or aneurysm in the coronary artery and you implanted a stent there. So sometimes even when you put it and you have a good result, probably the things will not go properly. So this is a gentleman, 39-year-old gentleman. Previously, he's healthy, and actually he developed chest pain while he's playing sport in the gym and transferred to our hospital with severe agonizing angina chest pain. ECG, probably there's some inferior ST elevation. And for us, this is an acute coronary syndrome, ST elevation, myocardial infarction. And we decided to take him to the cath lab. Definitely, echo showed the inferior basal hypokinesis later on done, and troponin at the time of the presentation was minimally elevated. So we decided to take the patient to the cath lab, and as you see, there is the LAD, the flow is probably slow, and we see the circumflex clearly. The mid portion, there is a tight lesion preceded by aneurysm or ectasia, swirling of the blood. We don't know if there is a thrombus or not. And if you look to the RCA, also the ostium is not clear. Probably there is a mild disease, and distally there is another ectasia and some lesion. So we decided that probably the calibrate, or actually the calibrate is the left circumflex artery. So I put a wire and I could cross the lesion easily. Then I started to do OCT, and the purpose of doing ECT to see the vessel and the ectasia or the aneurysm preceded the lesion to decide the stent size. And as you see, distally probably the lesion diameter probably 3.5. Now, if you look to the OCT result, severe stenosis at the site of the lesion, and proximal to the lesion, there is big aneurysm or ectasia, and even we couldn't clearly estimate, because full of blood or contrast, we couldn't clearly estimate the diameter of the vessel proximal to the site of the stenosis. So the patient having continuous chest pain during the procedure, he have even blood pressure started to drop, probably because of big vessel. So we decided to dilate the lesion. Balloon was 3.0, and we decided to use 3.5 drug-eluting stent. And actually, I put the stent to cover even the ectatic area or the aneurysmal area. So if you look down to the last image here, the result probably acceptable for us at that time, at least angiographically. And the patient have some improvement of the chest pain, blood pressure started to improve after we deployed the stent. But we know that probably the stent in the ectatic or aneurysmal area, it's under or malapposed. So I decided to repeat the OCT. So this is the coronary angio in the other view. And if you look to the OCT, even before you reach, if you look to the ECT here, definitely you will see, definitely you will see there is a significant space between the stent and the wall of the artery. Now just the OCT is moving. Distally, the stent is well opposed and expanded. Then when the OCT move, we'll see a huge malapposition of the stent inside the aneurysm. Now it becomes more clear that the stent is hanging inside the aneurysm, and there is significant space between the stent and the wall of the artery. That time the patient actually better, I said, the chest pain is better, blood pressure started to improve, and we decided to post-dilate this area, but unfortunately that time we are at night, we don't have a balloon, bigger balloon, because we estimated that the aneurysmal area probably 5.0 or even more than 5.0 millimeter. So we don't have balloon at that time on the shelf. And actually I decided to stop the procedure, particularly the patient is asymptomatic, and to give him some tyrofluban, to admit him to the CCU, trying to bring the balloon in the next day and to optimize the artery. So after we get a balloon, we take the patient back to the cath lab, and the wire in the circle, we decide only to optimize our stent. But if you look to the IVAS, actually we start with the IVAS. If you look to the IVAS, there's resistance when we put the IVAS, trying to put the IVAS inside the stent. At the beginning, we thought that probably the IVAS catheter contacted the stent, so probably there is this is the difficulty. And after that, the IVAS passed easily to distally, and we look to the distal part of the stent. I don't want to lose the time, but distally the stent is okay. Proximally there is a under or a malapposed stent, but at the proximal edge of the stent, we didn't realize. Actually, we realized later on that the wire passed behind the stent, through the strut, and inside the stent. So actually, we are behind it. The first part of the stent, we crossed it, and we went behind the stent, inside the stent. We didn't realize that, actually. That's our mistake, and we decided to inflate this area. And if you look to this image, you look to the balloon is inflated, but part of the stent seems away from the balloon. So that's confirmed that actually we went first of all with a small balloon, because we found even the large balloon difficult to pass the proximal stent. So we passed with a small balloon to create a space, and till this point we don't know that we are behind the stent, then we get inside the stent. And we inflated, and after that, after we inflated the balloon, we noticed that we crushed the proximal part of the stent, and the result became ugly. It's even much worse than before we intervened. So we decided to do some, that time, actually, we realized that we passed behind the stent, then we get inside the stent. So we tried to use another wire to go inside the ostium of the stent, or the proximal part of the stent, multiple times, then we failed. So we decided actually to crush this area. We decided to crush it because now part of the stent is crushed, part of that is opened. And even here, if you look to the balloon, seems behind the stent. And we decided to cover that area because now the proximal part of the stent, we went behind it, then we went inside the stent. So we dilated that part, and we decided to cover it by stent. And then we went by high pressure balloon, 5.0 balloon, and we reached to the area probably more than 5.5, something like that. And at the end, actually the IVAS is long run, we noticed that we covered the whole diseased area, and even we covered the proximal edge of the stent, which was crushed by ourselves. And even in the aneurysmal area, we have now better expansion or better opposition of the stent. I have a time? Yeah, actually this is the last slide probably. I want you just to see that during in the aneurysm we have good expansion now or opposition. Okay, so the intervention in the coronary ectasia aneurysm actually is challenging. Have to be careful, and probably. It's not probably, actually, for me, imaging is almost required, was always required, and other options might be considered to avoid the stenting. Probably you just put the stent before you reach the aneurysm, or maybe sometimes we use drug-coated balloon. Previously there was self-expandable stents, now it's not available. Probably to good result we might have if we used it. And now regarding these cases, we don't know, shall we follow them or just leave it if the patient is symptomatic? That's all. Thank you very much.
Excellent. Thank you very much for giving us time and sharing with us all the steps, which is, I think, very interesting. Comments, please.